All right, so thanks so much for coming. This is a re-recording of a talk for the U24 network. I am an assistant professor at UCSD, and I will be talking about neural mechanisms of affective touch and their effects in chronic pain. So I conduct research in affective and somatosensory neuroscience. That is how the nervous system perceives a mechanical stimulus and interprets it as painful, pleasurable, or neutral or something else. Last year's Nobel Prize was very exciting for somatosensory neuroscience because it was awarded for the discovery of the receptors for temperature and heat pain in the case of the TRPV1 channel, and for touch and proprioception in the case of the piezo2 channel. This is a tweet from Eric Lander, the president's science advisor, and he says, "A warm hug from a parent, child, or friend can work magic. Congratulations to David Julius and Artem Patapoutian on receiving the Nobel Prize for Physiology and Medicine for discovering what makes the magic possible, how we can feel touch and temperature." So I'd like you to close your eyes for just a moment and think of a time when touch completely changed your emotions. So how is touch so powerful? How does this work? The pleasure of touch can feel magical, and the pain it causes can cause enormous suffering. My research attempts to uncover mechanisms behind this so-called magic, although, as you may appreciate, I don't think that the receptors are the full story. They're just the beginning. Our network focuses on mechanisms and effects of touch and massage, manual therapies. So just to touch briefly on that, we know that musculoskeletal pain affects about half of the adult US population and is a leading source of disability burden. It's also the most commonly reported health reason for receiving massage. Massage therapy has shown short-term pain reductions in musculoskeletal pain, and also some evidence of prevention of chronic pain in rodent pain models. And yet, not a lot is known about the mechanisms by which soft tissue manipulation techniques, like massage therapy, target different tissues and conditions. So I approach this question of mechanism in two directions. One is the bottom-up pathway for perceiving a touch stimulus, and the other is top-down cognitive and affective factors that modulate touch processing in the brain and spinal cord. So on the left, we have the physical touch stimulus. It activates sensory afferents of different types. These have a lot of integration in the spinal cord, and then signals projecting up to the brainstem and the brain. And on the right, we have cognitive factors like mood and expectations and social context. So the same touch can feel very different depending on context. For example, the same shoulder squeeze from your partner could feel warm and reassuring, while that same touch from an airport screener might feel uncomfortable or alarming, depending on all of these social and cultural factors. Here are just two more examples. My research has focused predominantly on this bottom-up pathway, while still considering this top-down modulation. So I'll start with some brief background on C-tactile afferents, which have been the primary focus of this kind of bottom-up pathway for pleasant touch. So we have myelinated sensory afferents here depicted in yellow. These are nerve fibers that are wrapped in myelin that conduct their signal much more quickly. And these are associated with perceptions of light touch and cooling. And then we have unmyelinated sensory afferents, or C fibers. These conduct their signal much more slowly to the brain, and they are classically associated with pain and heat sensations. So these take about a second to reach the brain. If you've ever stepped on a nail, you'll have kind of a initial sharp sensation that is transmitted by A fibers, and then about a second later, kind of more dull, throbbing, aching sensation And that is the sensation elicited by the C fiber signal. But a subset of C fibers have been found to respond not to pain or heat, but to a gentle stroking stimulus. And so this has kind of spawned a small field of C tactile research. So C fibers that are for non-painful tactile sensations. These are recordings from 1939 in cats. But these fibers have also been identified using micronography in humans as of 1993. And so you can see a delayed response in C fibers in response to a stroking with a wooden pin in this case. And so what we see is that while most fibers on the bottom show a linear increase in their firing rate as the velocity of brush stroking is increased, C tactile fibers, this subset of C fibers, respond with a different profile, a sort of U-shaped curve, where they have their highest response to an intermediate velocity around 3 centimeters per second. And this corresponds to a slow, gentle stroking motion, similar to how you might pet a cat or comfort a friend. And interestingly, this correspondence between firing rate and velocity also translates to psychophysics. So it's the case that people tend to rate these intermediate 3 centimeter per second on average velocities as the most pleasant. And so there's a very strong positive linear relationship between the firing rate of C tactiles and pleasantness ratings. And while most researchers in the field don't any longer believe that these are labeled lines for pleasant sensation, they do seem to be fibers that are sort of honed to detect affiliative touch. They're really primed to prefer slow, gentle stroking on hairy skin and at skin temperature. And this type of stroking is frequently perceived as pleasant and rewarding. So this has led to the social touch hypothesis that C tactile fibers form a privileged pathway underlying social touch because they respond to slow stroking on hairy skin, correlate with touch pleasantness, and also there's evidence that they project to the insula rather than to somatosensory cortex. So there's evidence that the coding of more discriminative versus more affective or emotional aspects of touch is segregated starting in the periphery from these separate fiber types, and that this segregation is to an extent carried through the spinal cord and into the brain, where these fast conducting A fibers are projecting eventually more to somatosensory cortex, and these slower nerve C fibers are projecting more to the insula. But it certainly is more complicated than this. And there is now evidence as well of direct social kind of causal effects of C tactile afference on social behavior. In humans, C tactiles, slow brushing compared to fast carries an implicit positive affective value. So if you record from the zygomaticus muscle, which is essentially a measure of smiling, you get stronger activation to slow brushing than fast brushing. And slow brushing, which is, again, C tactile activating, also elicits sympathetic activation, so a slowing of heart rate and an increase of heart rate variability. And in animals, the sort of homologue for C tactiles, CLTMRs, functional deficiency in CTLMRs in mice induces social isolation and reduces tactile interaction. So this suggests there's sort of a potential social conditioning mechanism by which C tactile input may come to have its full kind of rewarding value. So investigations of the neural mechanisms for pleasant touch, and especially C tactile sensation, originate really with study of a patient with an autoimmune condition who basically had a loss of function of her A beta fibers. This is patient GL. She's been studied very widely, and she shows very extreme deficits in touch perception as well as in proprioception. And so she's wheelchair bound as well. So she was studied by Håkon Olausen, a co-I on this grant, and others. These are fMRI brain imaging data showing her response to gentle stroking compared to age-matched healthy controls. What you can see in the healthy controls is that there's a robust response in primary somatosensory cortex, this gentle stroking, some motor cortex activation, and then also secondary somatosensory cortex here involved often in kind of like texture and salience types of perceptions, and then here in posterior insular cortex. And what's notable about GL's brain scan is that she completely lacks this primary somatosensory cortex response and instead shows only a response in the posterior insula. So this has been one of a number of convergent pieces of evidence that the C-tactile pathway, like the C sensations for pain and temperature, project to the insula. So during my early work as a postdoc at NIH with Catherine Bushnell, I studied neural correlates of C-tactile touch pleasantness. And what we really wanted to do was to compare the processing of the more discriminative aspects of touch versus the kind of pleasant valence of C-tactile touch. And to do so in a to kind of obtain causal evidence in healthy individuals, because the patients who'd been studied may have had kind of abnormal brain plasticity or other compensatory processes that could alter their somatosensory processing. And so we conducted repetitive transcranial magnetic stimulation, or RTMS, which is a sequence of magnetic pulses that can either increase or decrease the activation of a focal brain region. So in this case, we used an inhibitory sequence to turn down processing in primary somatosensory cortex with the hypothesis that in parallel to the pathway for pain, this would affect touch discrimination, but not its pleasantness, not its affective characteristics. And that is indeed what we found. We also conducted repetitive TMS over secondary somatosensory cortex and had a similar finding of reduced touch intensity and no effect on touch pleasantness. And we were hoping to also reach the insula deeper behind that parietal operculum. Unfortunately, our group and others did not obtain evidence of being able to reach the insula with this coil. So we weren't able to kind of causally modulate insula activation to see its effect on touch pleasantness. We did, however, approach this question using fMRI in the same individuals. So here we conducted blocks of slow and fast gentle brushing on the hairy skin of the forearm and wrist versus glabrous skin of the palm, where C-tactile afferents are seen very sparsely. And so we were able to vary the intensity and pleasantness of the stroking somewhat independently by activating C-tactiles in the case of the hairy skin and not in the case of the glabrous skin. And so after each block, we asked our healthy adult participants to rate both the intensity and the pleasantness of the brush stroke. And then we looked for brain regions that were activated preferentially more in correlation with ratings of intensity versus with ratings of touch pleasantness. What we saw was brain activation in primary somatosensory cortex and secondary somatosensory cortex and the insula bilaterally in correlation with increased ratings of touch intensity. In contrast, we did not see insula in relation to touch pleasantness. We did see the pregenual ACC, anterior cingulate cortex, which is a brain area that is highly opioidergic and has been found frequently in relation to positive mood, placebo effects, and pleasant, other forms of pleasant sensation. And so we found this very interesting. This is somewhat in line with the parallel pain pathways for discrimination versus affect in more frontal limbic areas. The absence of insula activation is notable compared to some studies, but our study differed in that we really kept the touch identical in all ways, except for the activation of C-tactile afferents, whereas some other studies that have shown insula in relation to touch pleasantness also had differences in stimulus parameters such as the texture of the stimulus or the speed or intensity. So I think that's kind of an open question, the extent to which the insula is processing those kind of more early features of pleasant sensation versus the affect itself. So the frontal regions, including the pregenual ACC, that are activated by pleasant touch are also involved in descending pain modulation. This is pulling from a number of studies in addition to ours. And so this led us to wonder whether about the mechanisms by which touch can relieve pain. Is it through activation of some of these brain areas? So we know that pleasant affective touch can reduce pain. And in the lab specifically, C-tactile slow brushing compared to fast brushing reduces experimental heat pain. And a similar effect holds true for chronic pain. This is a circular rotary C-tactile device used in the study of chronic pain. Deep pressure, which I'll talk about later in this presentation, has also shown effects in reducing pain. And we know that massage can reduce pain with larger effects for deeper pressure. So this also led us to wonder about the condition of chronic pain, in particular because the activation we found in pregenual anterior cingulate cortex in relation to C-tactile touch pleasantness corresponds very closely to a region identified by my colleague Marta Checo that showed reduced gray matter in patients with fibromyalgia. And again, this is a region that's highly opioidergic. And patients with chronic pain show reduced opioid binding, which also occurs in rodent pain models, even in opioid naive animals, suggesting that chronic pain is associated with reduction in opioid receptors. So what might the functional consequence of this be on touch perception and the ability of touch perception to modulate pain, acute pain or chronic pain? So this led to a study where I was essentially able to add a task into my colleague's fibromyalgia study. We had patients with fibromyalgia and healthy adult controls receive gentle stroking on their forearm at both a slow speed and a fast speed in the context of a larger fMRI study. And what we found was that in the healthy controls, we found essentially the ubiquitous finding that slow stroking compared to fast, slow stroking is less intense, but is more pleasant than fast stroking. In contrast, on average, the patients with fibromyalgia were not making this distinction. And so while there was quite a lot of variability at the group level, we're seeing a large difference in perception of C-tactile touch, a lack of affective touch preference, essentially. So this suggests a blunted pleasantness response that's specific to C-tactiles. And I know since some groups have replicated this, while others have found an overall blunting of pleasant touch, regardless of the C-tactile nature. So I'm very interested in the mechanisms that may underlie these effects, whether they are sensory gating, the inhibition of ascending pain fibers by incoming light touch signals, whether it's social affective modulation, so activation of these brain areas associated with positive affect and mood, and their kind of descending modulation of pain signals, and or interoceptive exposure. So this is another model that I've been interested in. People with chronic pain often have a conditioned kind of fear response and pain response to both movement and sensation. And so gentle, pleasant touch may serve to decondition this fear of pain. All right, so switching topics a little bit, while conducting all this C-tactile research, I also became very interested in other forms of affective touch that we can study in the lab, and what their mechanisms are. And so one that I really honed in on is deep pressure. And we see deep pressure used in the swaddling of infants, in hugs, in massage, and in compression therapies that are used in both psychiatric treatments and manual therapies, often for individuals with autism, anxiety, ADHD, and other conditions. And there have been some small studies showing parasympathetic nervous system response to deep pressure, but the mechanisms are largely unknown. So we wanted to study mechanisms of deep pressure perception and see if we could elicit kind of a positive affective response to deep pressure in the lab in a non-personal manner, and also in a manner that was MRI compatible. Since we can't have ferromagnetic devices in the MRI scanner, we used a compressed air tank that was controlled by a programmable device where we could set the outflow of air into what is a lymphedema compression sleeve, actually. And so we just chose 2 chambers to inflate. And we found that static compression is rather aversive at a high level, like a blood pressure cuff, but an oscillating kind of moderately deep pressure is frequently perceived as quite pleasant and kind of massage-like. So we did some pre-piloting and some piloting. These are some of the pilot data comparing affective response to light and deep touch. So here we had healthy adults rate different adjectives for slow brushing in green and deep pressure in blue, and you can see a very similar affective profile where both sensations were rated as comfortable, calming, relaxing, enjoyable, and pleasurable. So this was encouraging, and we also found similar effects on mood. So slow brushing increases ratings of calm, decreases anxiety, fast brushing does not. And one of the 2 deep pressure levels that we tested also exerted a calming effect. So then we moved into brain imaging to look at neural response to deep pressure in comparison to brushing. And we saw similar but distinct neural response. So here we see robust primary somatosensory response in a very similar location. We also see secondary somatosensory response, which was bilateral in the case of brushing and not in the case of compression. We do see a little bit more dorsal parietal activation, extending a bit more dorsally in the case of compression. And then we see really interesting trends in the insula. There were no significant differences here in our data set, but there is this kind of strong visual trend towards more posterior insula representation of a brushing stimulus versus more mid-insula representation of the deep pressure. And this is notably also an area that is activated by kind of warm temperature sensation. These were the significant differences between conditions here in the ipsilateral secondary somatosensory cortex, and then here kind of along the somatosensory cortex a little bit more dorsal. So this is these are intriguing differences. We're interested in, kind of differences in the is compression considered more represented more as a bit more of a visceral sensation, and does it have kind of different affective consequences? So we're hoping to follow up on this. And I also wondered about the mechanism for affective deep pressure perception. So does deep pressure activate C-tactile afferents? Does it activate other afferents that may have a closer link to affective perceptions? And I was very fortunate at the NIH towards the end of my postdoc to be able to study two very unique patient cohorts. Both of these cohorts had severe somatosensory and proprioceptive deficits. So I was able to study GL and a second patient who lacked A beta afferents. And then I was also able to study patients who were newly identified at the NIH at the time by Alex Chesler and others who lacked functional piezo2 ion channels. And so these are individuals with severe deficits in light touch perception and proprioception, and therefore kind of these joint deformities. And all these patients experienced deficits in perception of light touch and vibration, but had fairly normal pain and temperature sensation. And so we wanted to test their ability to perceive deep pressure touch to see whether it was possible to perceive in the absence of A fibers or piezo2 channels, and whether it still felt pleasant. So our first finding was that A beta deafferented patients had no perception of non-painful deep pressure touch. So this is one of the more kind of obvious, striking, very apparent effects in my scientific career. We could, shake hands, we could touch their arm or their back, and they were unaware. So we administered several tasks to kind of quantify this lack of deep pressure sensation. One was with our compression sleeve, where we showed that healthy adults kind of rate the intensity of the compression sleeve at this kind of moderate amount, whereas our patients, one rated no sensation and one said that he might have felt something on the trials. He was not sure. And so he rated a little bit of perception. And then similarly on a two forced choice discrimination task of a kind of light sleeve squeeze versus a deep sleeve squeeze, we found that our healthy controls differentiated these with 100% accuracy, whereas our patients did not. We then used a blood pressure cuff inflated manually around the upper calf to ask our patients and controls when they first perceived any touch sensation right here, and then when they first perceived any pain sensation. And our healthy controls perceived the very lowest amount of pressure as we began to inflate the cuff, and this is with blindfold and noise blocking headphones, so no other sensory cues, whereas our patients were unable to detect this pressure until it reached a very high level. This is like when you have your blood pressure taken. In contrast, for sensing any pain, our healthy controls sense pain in the 100 to 200 millimeter mercury force level, whereas our patients did not report any pain until a higher level. And what's really interesting here is that our patients are essentially not detecting any touch until a level of pressure that is equal or higher to when our healthy controls are perceiving pain. And so this suggests that they're relying on the activation of pain fibers to detect pressure. They're lacking non-painful touch afferents, essentially, deep pressure afferents. And we got a very similar finding with a pressure algometer on the thumbnail. Okay, so then moving on to the patients who lacked piezo2 ion channels, this was a big surprise. They had normal deep touch perception. So they were perfectly good at perceiving the intensity of the deep pressure and at differentiating a gentle versus a stronger dose of pressure. And what this suggests is that non-painful deep pressure sensations are mediated by A fibers, but not by piezo2 receptors. And this is, again, kind of a surprise because piezo2 receptors are abundant on most A fibers, but I suspect this may relate to deep pressure sensations potentially being perceived via afferents originating in deeper tissue types like fascia and muscle, where we know less about the molecular mechanisms. And so this suggests the presence of a non-piezo2 molecular mechanism for deep pressure sensation that I'm sure is under active investigation. So this is a little humble brag that on the Nobel Prize website last year, our paper was one of the papers listed as background relevant information. And in the illustration of the Nobel Prize, there was a kind of frequent depiction of a hug interaction, which certainly kind of conveys this, magic positive aspect of touch, but is also a bit inaccurate since we found that piezo2 is not the mechanism for deep pressure perception. Piezo2 deficient patients still feel, and we believe, although it's hard to quantify, enjoy deep pressure. The quantification was difficult because of difficulties in kind of translating. Our patients were not native English speakers, and in addition, since they had such an absence of touch sensation in their daily life, most touch sensations that they perceived were felt important and special, and so it was kind of difficult to compare their affective responses. But we did have some who reported appreciating receiving massage. Okay, so I'm going to switch just a little bit to back to the C tactile fiber story. So there has been a kind of longstanding belief and a number of pieces of evidence that this pleasant, gentle, striking sensation is conveyed by C tactile afferents. And yet there was a very surprising finding by Marshall and colleagues in 2009 that when the anterolateral quadrant of the spinal cord is ablated for the purpose of trying to treat intractable cancer pain, pain sensations are vastly reduced, and yet slow stroking pleasantness is maintained. And this was a big surprise because it was believed that these C tactile fibers would follow the predominant pathway for C fibers in this anterolateral quadrant. And it suggests the potential involvement of A fibers, that perhaps there is a redundant signal or sort of pattern recognition from the A and C fibers as they are conditioned during development that leads to the interpretation of a pleasant sensation. And this is something we really wanted to follow up on since this work was conducted in patients with enormous pain. And so I have been following up in healthy adult controls, first at the NIH using ischemic compression blocks, and then in my own lab at UCSD using nerve compression blocks. And so the idea here is to essentially numb A fibers, at least preferentially, and then test whether A fibers play any important role in perceiving this gentle brushing stimulus. So we first use ischemic compression block, which is the inflation of a blood pressure cuff very tightly around the upper limb, and it cuts off blood flow. It makes your arm kind of lose color and sensation. And usually around 15 minutes, there's a loss of A fiber associated sensations like vibration. And before the nerve block, and then after this loss of afiber sensation, we tested the pleasantness of slow gentle stroking with a brush. So we got some good data from this technique. However, while it's quite effective, it is also often quite aversive. So this technique can elicit kind of pain and also kind of autonomic response, disgust, aversion, as the limb is lacking blood flow. And so here at UCSD, we have been using the compression technique, where we dangle a weight from a tourniquet, and we wait usually up to about an hour until there is a loss of vibration perception and a drop in cold thresholds, signaling a significant drop in afiber function. And what we find here is that from before to after nerve block, there is a near elimination of intensity perception from gentle brushing, and also pleasantness perception from gentle brushing. And I'm not showing it here, but there's virtually no change on the control arm over this same time course during the same procedure. So this strongly suggests that afibers are necessary, at least for the explicit perception of the intensity and pleasantness of what we think of as C-tactile brushing. So while patients who lack afibers, may still be able to detect this C-tactile signal, in most of us, we may need these convergent signals in order to interpret touch pleasantness. All right, so moving back a little bit to deep pressure and to pain, one of our more recent studies here at UCSD that is underway, we've been interested in understanding, comparing deep pressure and gentle brushing and their effects on acute pain. So we've been performing this with the conditioned pain modulation task. This is a task where normally a initial heat stimulus of one type is applied, for example, to the arm, and then a second conditioning stimulus of a different type is applied, and then the test stimulus is brought back, and we look for any reduction in pain due to the conditioning stimulus. And so this is generally compared to trials without the conditioning stimulus to see what is the effect of one pain on inhibiting another pain. And this has been implicated in endogenous pain modulation with deficits shown in many chronic pain patients. So we adapted this task for affective sensation. We used a slow stroking brushing sensation and also a deep pressure oscillating compression sensation, and also a neutral kind of tapping condition. We're studying this in healthy adults as well as adults with fibromyalgia. This is work in progress, so everyone is collapsed together right now. This is data from last fall. And what we're finding right now is that our affective and neutral stimuli are rated very similarly in terms of their intensity, although the cold water bath is much more intense. And their pleasantness, as expected, highest for brushing, kind of moderate for pressure, lowest for tapping, and much, much lower for the very cold water bath. And what I think is interesting is that we're seeing the largest CPM effect, the largest pain reducing effect from both the cold water bath and the deep pressure, followed by brushing and least by tapping. And I think it's interesting that the pain relieving effects of pressure don't appear to be fully explained, at least by subjective ratings of its intensity or its pleasantness, suggesting some additional mechanisms at play. So this is work underway, and there are some more things we'll learn about mechanism from this study. Finally, my lab has been taking a little bit of an applied direction. I have long wondered about the effects of deep pressure as conveyed by a weighted blanket and its potential to reduce chronic pain. So this is something that we had the opportunity to test during the early period of the pandemic. We knew that weighted blankets can reduce anxiety from a number of small studies. And there was also the recent publication of 2 large randomized clinical trials showing that a heavier weighted blanket compared to a lighter weighted blanket induces large reductions in sleep disturbance in both healthy adults and those with various psychiatric conditions. And since anxiety and sleep both strongly modulate chronic pain, in addition, deep pressure has this kind of affective effect, I hypothesized that a heavy weighted blanket compared to a light weighted blanket would reduce ratings of chronic pain mediated by improvements in anxiety and sleep in a population of individuals with chronic pain. So we tested this hypothesis remotely during the early phase of the COVID-19 pandemic. We conducted our recruitment through the Research Match website, where individuals with chronic pain had already registered as self-reporting a diagnosis of chronic pain. This is a very heterogeneous sample of anyone who had previously signed up reporting chronic pain. We had 130 individuals enroll in the trial and 102 complete all study sessions. We randomized each participant to receive either a 5-pound weighted, light weighted blanket or 15-pound heavy weighted blanket, twin size, and asked them to wear it overnight for 7 nights. And over this week, we collected initial kind of survey data in REDCap and then daily ratings of pain, mood, and more in Life Data, which is a smartphone application that implements ecological momentary assessment, basically just collecting ratings in real time from the participant's home and daily life. This is just what a prompt on the participant's phone would look like, rating their current level of pain. And this was one of our outcomes. Primary outcome was pain intensity, and secondary outcome, PEG, which is the 3-item scale describing both pain intensity and pain interference. So while we found no significant effect on pain intensity, we did find a significant effect of the heavy blanket compared to the light blanket in reducing chronic pain. This was a significant, though barely significant, interaction. But what was very striking and highly significant was a effect such that individuals who were high in trait anxiety were really driving this pain relieving effect of the heavier weighted blanket. And so it's seen that those who were high in trait anxiety really benefited from a heavy weighted blanket in reducing their chronic pain. We also conducted some exploratory analyses that are in press now, or secondary analyses, I should say, that we had hypothesized. And here we were looking at ratings of social connectedness, which is a trait-like measure measuring the extent to which you feel close to other people or tend to feel close to others in general, regardless of how connected you actually are, how social you actually are, how easily do you feel closely connected to others. And what we found was that higher social connectedness was correlated with lower chronic pain. And so this kind of echoes findings from the loneliness literature, but contributes this kind of novel understanding that kind of a cognitive representation of how close or not close you feel to others may exert an additional influence on chronic pain. We found this relationship between social connectedness and PEG scores was mediated by anxiety, suggesting that feeling more less close to others would increase anxiety and increase pain, and vice versa, potentially. And finally, we looked at the role of social connectedness in the effect of a heavier light blanket in relieving pain over this 1-week trial. And what we found was really interesting. We found that in those who were more socially connected, there was no difference in the effect of the heavy versus light blanket. But in those who were less socially connected, the heavier blanket was really necessary for pain relief. The light blanket was not sufficient for pain relief. And so I think there's a lot to unpack and a lot of room for follow-up research to really understand this finding. But I think it really points to close connections between affective perceptions of deep pressure, affective perception of touch, and feelings of closeness and social proximity to others. And of course, the relationship, we know there's a strong relationship between social perception and pain. So this is also work I'm very interested to follow up on, and I'm excited that we have funding, a new grant funded at the VA to study pain and sleep in veterans with chronic musculoskeletal pain and sleep disturbance. All right, so I think I will wrap up here. In summary, touch has many magic effects that are conveyed by a multitude of distinct pathways, and there are so many exciting directions for both mechanistic work and clinical applications. And we hope that our U24 network will inspire more work, more exciting discoveries on these mechanisms and applications. So with that, I would like to thank and acknowledge my longtime mentor, postdoc mentor, Catherine Bushnell at NCCIH, and then many, and Hoken and Jaquette and Lin Chiping were close collaborators on much of my postdoctoral research. And then all the individuals at UCSD who have helped my lab launch and conducted some of this research, including Jennifer Baumgartner, a postdoc, and then Vince, Marissa, Desiree, Jacob, and others. So thank you so much for your attention.